National Institute. We will start by Professor Gamal Amira. Dr. Mohammed Mahdi will take over Dr. Gamal. We will talk about breast surgery in the era of neoadjuvant therapy.
بسم الله الرحمن الرحيم. أولاً حابب أشكر دعوتي على المؤتمر وأشكر السادة الموجودين. الشيرمان دكتورة هاجر تقريباً قالت المحاضرة بتاعتي. فهي محاضرة جراحة. دكتورة هاجر قامت بالواجب. فإن شاء الله أنا هتكلم على الدي اسكاليشن of breast surgery according للبريست tumors and to the axilla. First option, treatment option of breast cancer needs multi-speciality. This must be done through MDT. MDT solve difficult problems. The story of breast surgery started with William Halsted, in which Halsted do radical mastectomy. It was aggressive surgery, good removal of entire breast, level 1, level 2, and level 3, and removal of chest wall muscles. Halsted stated that lymph node acts as a barrier for lymphatic distant lymphasis. This is Halsted radical mastectomy. Is this acceptable? Now, no. Halsted was aggressive surgery, did it improve survival rate, have a high morbidity, and died more than 100 years ago. Then we go for another escalation with Fisher. Fisher stated that lymph nodes are ineffective as a barrier to tumor spread, and lymph nodes are of biological importance only, and tumor can spread to systemic and lymph nodes at the same time. Breast cancer is a systemic disease. Then modified radical mastectomy replaced radical mastectomy of Halsted with removal of entire breast, level 1 and level 2 axilla, no muscles removed, like major or minor. We started with radical mastectomy de-escalation, then modified radical mastectomy. We are going now for an era of breast conservative surgery. The first study is NISAB B06, in which patient with early stage breast cancer, T1, T2, randomized to have breast conservation versus total mastectomy. There is no difference in survival at 20 years. Lumpectomy without post-operative radiation therapy have a higher local recurrence, 39 versus 40%. Breast conservative now are standard of care according to NISAB B06 for stage 1 and stage 2 disease. Addition of radiotherapy to lumpectomy decreased the local recurrence in patient who is not positive from 44% to 9%. Why breast conservative surgery? Breast cancer is a systemic disease. Local radicality doesn't improve survival. Cosmetic consideration, psychological importance for patient, minimize local recurrence at the primary site, acceptable cosmetic results, eradicate microscopic foci of tumor with radiotherapy, minimize complication, good quality of life. We are now moving from breast conservative surgery from early stage breast cancer to locally advanced disease T3 and T4. According to NISAB B18, randomized to receive neoadjuvant chemotherapy, then have breast surgery, or go for upfront surgery. 12 more lumpectomies performed in neoadjuvant group, and 175% increase in breast conservation if tumor more than 1.5 centimeter. According to NISAB B18, there is no difference in disease-free survival or overall survival between patients receiving pre-operative or post-operative neoadjuvant chemotherapy. But there is increase in overall survival in patients with a complete pathological response. Breast cancer is not one disease. زي ما احنا عارفين في multiple types, luminal E والluminal B والHER2 والtriple negative. Also triple negative also is not one type. Have some molecular subtypes, basal-like 1, basal-like 2, immunomodulatory, mesenchymal, mesenchymal stem-like, luminal and renal receptor. Given the aggressive biology and high risk of distant recurrence, triple negative HER2-positive disease, systemic therapy is needed in most patients. Neoadjuvant chemotherapy benefits patients with locally advanced disease by downsizing the tumor and increase possibility of breast conservation, but also in patients with triple negative and HER2-positive, adding neoadjuvant add a survival benefit to these patients. The challenge in surgical management of primary tumor after neoadjuvant chemotherapy, in which tumor shrink, pattern of tumor shrinkage, concentric pattern of shrinkage, or honeycomb pattern of shrinkage. We need a tool to assess our response to chemotherapy. Thus, most guidelines, the NCCN, ESMO, EGO, recommend follow-up patient with neoadjuvant chemotherapy with MRI. According to safety margin, NCCN والسانجالين والإسمو والEGO والNICE, ink-free margin is sufficient for invasive disease, and more than 2 mm is sufficient for DCIs. Before going for neoadjuvant chemotherapy, as a surgeon, to do breast conservative surgery, we should have a clipping tumor before starting neoadjuvant chemotherapy, as with increased rate of pathological complete response, radiological and clinical complete response, we can't detect the site of the tumor. So all guidelines in NCCN or EGO or ESMO or Breast American Association recommend putting clips before neoadjuvant chemotherapy and wire localization before going for surgery. According to NCCN والإسمو والسانجالين كل guidelines recommend using neoadjuvant in high-risk patients, HER2 triple negative, and ethical obligation not only for downsizing the tumor but also survival benefit with pathological complete response. We now shifting the escalation of axillary surgery. Axilla started early with axillary lymph node dissection, standard of treatment. We now in the era of central lymph node. Central lymph node is defined as the first node in the regional lymphatic basin that receive lymphatic drainage of primary tumor. First study to assess sensitivity of central lymph node was NISAB 32, in which patient with node negative randomized to do axillary dissection versus lymph node and followed by axillary dissection. To detect the identification rate was 97% and false negative rate was 9%, and the average of central lymph node retrieved about 3 lymph nodes. With decreased false negative rate زي ما احنا شايفين كده، كل ما بنزود عدد ال retrieved nodes كل ما بيقل ال false negative rate. If we retrieved more than 4 or 5 lymph nodes, false negative rate drop below 4%. And sentinel lymph node is safe and appropriate and effective in patients with clinically negative nodal disease. And there is no difference in disease-free survival, overall survival, and the local recurrence between patients who have sentinel lymph node only with lymph node negative disease versus patients with sentinel lymph node and axillary dissection, with more complication in the arm of sentinel lymph node and axillary dissection versus sentinel lymph node only in the term of lymphedema, arm numbness, tingling, shoulder abduction deficit. We're now shifting from sensitivity to omit axillary lymph node dissection in early stage disease T1 and T2 with one or positive sentinel lymph nodes in this established trial, Z0011 trial, in which patient randomized with early stage disease with node negative to have sentinel lymph node. If we retrieved one or two sentinel lymph node, arm complete axillary dissection and another arm we just enough sentinel lymph node. There is no difference in disease-free survival or overall survival between patients who have axillary lymph node dissection versus sentinel lymph node only in patients with retrieved one or positive lymph node. Z011 trial, the standard of care, and have a 10-year overall, so not inferior to axillary dissection, which is a standard of treatment in the term of long-term disease-free survival, overall survival, but less morbidity of axillary dissection. Another trial to assess sensitivity of failure of axillary lymph node after sentinel lymph node dissection In this trial, there is no difference between patient have central lymph node versus axillary lymph node dissection in terms of disease-free survival and overall survival. SINODAR is another powerful trial with intention to treat analysis to assess long-term axillary failure after central lymph node biopsy. There is no difference between axillary recurrence in arm of axillary lymph node dissection versus central lymph node only in the term of axillary failure. We are now shifting from central lymph node to avoid axillary surgery with Amaros trial, in which patient with early disease T1 and T2 with central lymph node negative with node negative disease randomized to have central lymph node. If central lymph node negative, no further treatment will be done. In patient with central lymph node positive, قسموا الاثنين arm complete axillary lymph node dissection and another arm radiotherapy to the axillary. With no difference in disease-free survival or overall survival between patients who have axillary lymph node dissection versus axillary radiotherapy. With less lymphedema in the arm of axillary lymph node dissection only, with axillary radiotherapy only, as we see in blue color versus orange color in this graph. Amaros is non-inferior, adding radiotherapy with positive lymph node, non-inferior to axillary lymph node dissection with less complication of lymphedema of axillary lymph node dissection. Now he's shifting from central lymph node and neoadjuvant after adding neoadjuvant therapy in clinical N1 and N2 disease. The first trial to assess sensitivity of central lymph node after neoadjuvant therapy is Sentina trial, in which patient with clinically positive nodal disease N1 or N2 disease who received neoadjuvant chemotherapy and turned to N0 disease randomized to have central lymph node followed by axillary lymph node dissection or go for axillary lymph node dissection upfront. Result of Sentina trial, the number of removed lymph nodes was significant predictor of false negative rate. False negative rate was 24% with one lymph node retrieved and dropped to 9% with two or more central lymph node retrieved, and false negative rate was 60% when radicolloid alone was used versus 8% when radicolloid plus blue dye was used for lymphatic mapping. Alliance trial is another trial to assess false negative rate with central lymph node after neoadjuvant chemotherapy. The same result as Sentina trial, when more than two central lymph node identified, false negative rate was 12%, but was 10% with dual agent mapping and 9% with 3 or more lymph nodes retrieved. زي ما احنا شايفين الفرق ما بين السنتينا والزي 1071 والترايلز كل ما بزود if we increase number of retrieved lymph nodes false negative rate drop معانا. يعني if we retrieve more than central lymph nodes false negative rate drop even below 7%. MD Anderson experience in the clipping of biopsied lymph node targeted axillary therapy when added central lymph node and removed clipped nodes, false negative rate dropped to about 1%. Clipped lymph nodes was not central lymph node in about 23% of patients. This is known as targeted axillary therapy. This is another studies that assess targeted axillary therapy. As we see, false negative rate drop below 4% when adding central lymph node with targeted axillary lymph node dissection. As we see in all guidelines in NSCN والسان جالين والإزمو والنيس, we have central lymph node after neoadjuvant chemotherapy. When initially patient have N0 disease, we go straight forward for central lymph node biopsy. And the patient with turned N1 to N0 disease, all guidelines recommend going for central lymph node biopsy مع اخذ في الاعتبار الحاجات اللي قلنا عليها اللي هي بتقلل الفولس نيجاتيف ريت اللي هي ريترايف مور ذان 3 lymph nodes ودول مابينج براديو اكتيف تريسر والبلو داي. If still no positive disease after neoadjuvant chemotherapy, will go straight forward for axillary lymph node dissection. sentinel lymph node في المايكروميتاسيس مفيش فرق برضه، احنا بنجو فور sentinel lymph node only and no need for axillary dissection. Other new technologies used for lymphatic mapping indocyanine green with supramagnetic iron oxide nanoparticles in patient with sensitivity to blue dye or radiculum. Sound trial, another trial to assess either to do sentinel lymph node or no axillary staging at all, in which patient with early stage disease T1 randomized to have sentinel lymph node biopsy versus observation by ultrasound guidance of lymph node, and if lymph node, if axilla negative by ultrasound or negative fine needle aspiration cytology, we go for follow-up. These randomized trials evaluating combination of sentinel lymph node, sound والإنسيما trial, we no difference في disease-free survival, overall survival, or quality of life between patient have sentinel lymph node and the only observation of axillary lymph node with fine needle and ultrasound. Take-home message: all breast cancer patients should have a core biopsy for diagnosis. Pathological report of core biopsy should include information about ER, BR, HER2, and KI. Applying clips for breast conservative surgery before neoadjuvant chemotherapy, neoadjuvant chemotherapy for high-risk patient, HER2, triple negative for advanced disease. This is the past. Thank you.
Dr. Mohammed Dia, just one question.
The sentinel lymph node biopsy revolutionized all the treatment of the axilla. So in limited resource settings, sometimes we don't have the dyes, like the blue dye or the indocyanine green or the radioactive isotope. How can we deal with this situation, in your opinion? It's a question for you and for all the audience, actually, because it's a situation that we meet sometimes when we don't have the dye. So this will convert us to axillary lymph node dissection again?
No. I think we should go for ultra staging by removal only of enlarged lymph nodes or axillary sampling only, just level 1 or blue if there is no resources only.
You go for axillary sampling? What is axillary sampling?
What is axillary sampling? It's حاجة فضفاضة كده، طبعا مختلف من الرحل تاني.
No. I would like to know the opinion of the surgeons here. If anyone. No, this is not.
not the standard of care. أنا قلت لك حضرتك أنت بتجاوب على حضرتك سؤال معين.
Yes.
لكن أنا ما بعملش كده. أنا شخصيا ما بعملش كده. أنا معايا البلو داي بجيبها.
No, I'm talking not about your own personal experience. I'm talking about as an institution or in places where there is no dye, because this is a situation that we have here in Egypt and in many countries who doesn't have enough resources. Because this will change completely the management of the axilla.
I have an idea.
Yes.
Maybe applicable. We should go for sampling and go for frozen section. If positive, we go for axillary dissection. If negative.
Okay, I would like to, yes, please, Professor Sarah, please.
Thank you. I really enjoyed your talk. And you know, as obviously I'm a great advocate of us de-escalating surgery when it gives no benefit to the patient. But in the UK, we use mag seeds, and they're so much easier than hook wires, and you can put them in early. So you can put them in before neoadjuvant. They're only for 6 months, but you can still do that. And equally, they're so easy to find in the axilla. I went to a very nice presentation about axillary dissection in terms of what a sampling was, where Mark Kissin, who is a great surgeon in the UK, had a bag full of golf balls, and he put 4 golf balls in and said, now, rush them into the round, pick out the 4 that were an axilla, you know, that there was no, it was not in any way targeted, and really to emphasize the importance of having some targeting. There are various methods. Blue dye is not expensive. Mag seeds are not expensive. How much does Herceptin cost? 22 grand, £200.
It's not about the costs. It's
Availability.
It's not about the cost.
Availability.
Yeah. Sometimes it used to be present for a while and then it disappears. It depends upon the economic situation in many countries. especially when it is insured or it is provided by the government. It's related to an economic situation that might be present sometimes or not. So my question is, axillary sampling is an accepted solution?
Axillary sense, I think it's very difficult to be accurate because, as you described, it is operator dependent, I think is the phrase. And so it's much less, you wouldn't have the false negative rates that we've seen in these trials. You have to have targeting.
So you have to do axillary lymph node dissection if you don't have the dye?
I would say yes.
Yes, please.
We have all the problem of patent blue is not available. Also, the radioactive material is not easy to. So the dual is very difficult, but I think we have the methylene blue, and it has a very high accurate rate, like the patent blue. I know when to get and how to sterilize, but they use the gynecologist would use the methylene blue.
Methylene blue always doing the field stain.
It is used in axilla negative by imaging and by clinical to try to proceed for sentinel better than to not use it at all. In the future, the Maxid will be available in Egypt. It's going to be to take a license now, so it is dual. Depend on the using the magnetometer, the SPIO, and the lymph node will be stained. So it is dual by one machine and very easy. It's going to be licensed in Egypt. I think within a few months will be available in Egypt.
What about your experience in Mansoura?
I think we have patent blue 6 months ago. Now we use the methylene blue.
What about detection rate with methylene blue?
Sometimes post neoadjuvant the rate is very low. It's okay. Sometimes there is no dye because the chemotherapy can affect the lymphatics, but the detection rate is up to 85%, up to 90%.
What I know about the methylene blue is that its molecular weight prevents it from being available in the lymphatics for a long period of time. So that's why most of the world doesn't use methylene blue for the axilla, and we use patent blue because of this, because of its large molecular weight that stays longer in the lymphatics. So I'm not aware of any data about the success of methylene blue. Do you have this data?
I think the data, always the Indians search for more economic material to solve their problem. And the Indians use the methylene blue as a standard. They don't have patent blue at all. And a lot of research about the methylene blue and the use of methylene blue, I think in a lot of research it is accurate as patent blue. But we take a long time, massage for a long time, instead of 5 minutes in patent blue take more time.
I need to highlight, we must standardize and have a technique for using methylene blue.
Yes, it take a long time. Sometimes if you use the same technique like patent blue, you will open the axilla and you will not find the so massage more. Take more time after 10 to 12 minutes to detect the.
I think indocyanine also is a good option. Indocyanine green is the.
experience في using المثلين بلو تكنيك ازاي احنا بنشتغل بيه ويكون في حاجه واضحه ممكن لو انتوا حضرتك تشتغلوا بيها.
Yes, the indocyanine green also I think is not available and it needs a camera. You
Yeah,
should have a seat.
The camera is the only thing that is expensive, but the dye itself is not. So if an institute or a hospital can buy the camera, I think this will serve many, many options other than the axillary lymph node biopsy or the sentinel lymph node biopsy. Yes, please, Professor Dr. Munir, please.
I was just going to say, you'll be very happy when you don't have to use hook wires as surgeons.
After following these talks with Dr. Mahdi, Dr. Hagar, and this fruitful discussion, experience of Mansoura, Tourid Nahas, you will see that it is a dilemma. So, after 50 years experience, I would emphasize that management of axillary in breast cancer should not be taken unless in an MDT. Why? I am afraid that many surgeons following this will have the false impression that we have to do less and less surgery for the axilla. Any surgical oncologist acquainted with this field knows very well the horrible situation of what we call axillary recurrence. So until then, until we have these facilities in hospital, I would highly recommend complete axillary dissection unless it is in a high volume center with an MDT. هرجع لهيستوري قديم القرن السنشري ال11 الطبيب العربي البوكاسيس أبو القاسم الزهراوي قال we have to remove the balls in the armpit. This is his language at that time. معناها ان هو عمل ماستكتومي وعمل axillary dissection. فانا برجع لهذا التاريخ until we have this ideal situation we have to do a complete axillary dissection.
Professor Munir, MDT now is available in a lot of hospitals, but still the private sector has a problem. You talk about it. There is no MDT in the private sector.
We also should balance we should do the balance between the resources that we have and the guidelines. This is very important because we cannot omit all the guidelines and say that we don't have the resources, so we go back 100 years ago. This is not completely right. We should modify the guidelines or try to find solutions for the problems that we have related to the resources. This is very important, I think. Yes, please. Yes.
Thank you for speaking. For those of us who have seen axillary recurrence, it is such an abhorrence. It's incredibly painful, impossible to treat, and a disaster. Fortunately, certainly in my practice in the UK, my more junior surgeons have never seen it. It's so important that we move forward because that is what we're trying to avoid. Axillary recurrences are rare, but when they occur, they are so awful. And those of us that have seen them find it very hard. I found it very hard to move from an axillary clearance for every cancer to less surgery. And it's so important that we work as an MDT with our colleagues and that we have the right tools so that we are able to both avoid those axillary recurrences whilst also reducing the impact of an axillary clearance. Thank you.
Thank you, Professor Sarah. We will now shift for Professor Walid Nahas, Professor of Surgical Oncology, Oncology Center, Mansoura University, and he is the director of the Oncology Center and one of the best surgeons in breast surgery. He will talk about skin-reducing mastectomy with immediate reconstruction with pre-pectoral implant.
في البداية شكرا دكتور إبراهيم على المقدمة الجميلة. Thank you Mr. Chairman. وبشكر طبعا الأورجنايزنج كوميتي. As we know, there is a lot of types of mastectomy ranging from modified radical and the Halsted
or the radical mastectomy, which is historical now. Also, there is now 4 types of skin sparing mastectomy, which is based on the types of incision and the amount of excised skin. Skin sparing mastectomy or nipple sparing mastectomy was in non-pendulous small breast. It is very easy, but if there is a large breast, so it needs for reduction of the pocket, which is our talk today. The skin reducing mastectomy able to be performed for patients who had moderate to large sized ptotic breast and no history of previous reduction mammoplasty and absence of tumor affecting the skin, excluding the smokers and patients with microvascular problems like non-controlled diabetes. The operative plan for the skin reducing mastectomy is like all the breast surgery. While the patient is standing, in skin reducing, in the classic skin sparing mastectomy, no need for, or nipple sparing mastectomy, no need to reduce the pocket, and always the rate of complications is very low. Either we proceed through inframammary incision or radial incision or or periareolar incision, but when the breast is pendulous like this, so we need to perform a type of, if we proceed for mastectomy, we should reduce the pocket to fit the reconstruction, either using the implant or any LD or the tram. So the patient, we draw the wise pattern, classic wise pattern, or the Lejeune vertical mammoplasty, and then we proceed for the mastectomy. If the degree of reduction of the pocket is small, so we can use the Lejeune, but if we need a large reduction of the pocket, so the T-shaped incision is used. All of us face the complications of mastectomy or skin reducing mastectomy or nipple or skin or nipple sparing mastectomy of the wound healing. And there is 2 points, always there is delay in wound healing in the vertical, in the meeting of the vertical and the inframammary scar. And this, if there is wound healing problem and we reconstruct by the implant, so there will be exposure of the implant and the failure of the reconstruction. Also, there is a lot of cases facing from nipple areolar necrosis. So what is the ideal technique for skin reducing mastectomy? I think one technique cannot fit all. So sometimes if the degree of reduction or the degree of reducing needed, I think the nipple areolar complex grafting will be more suitable. But if the degree of mastopexy is small, so we can use the vertical or the just to wrinkle the vertical limb and the transverse to wise pattern to decrease the complications. By augmenting the pocket or adding a new tissue layer at the lower pole of the breast, because this T-shaped part is the more susceptible for necrosis, so we can avoid a lot of complications. This video I will show you a lot of techniques we used for skin reducing mastectomy. This case of multicentric breast cancer. This is the Lejeune marking. We start by de-epithelialization of the tissue around the nipple and areola, as we are doing mastopexy or skin or reduction. Then we, through the medial limb, we inject and then we start to dissect sharp dissection between the breast and the subcutaneous tissue, and proceed by sharp dissection. We don't use the diathermy in superficial dissection, and then medially we proceed, and then when we reach under the nipple and the areola, we send the tissue under the nipple and the areola for frozen section. Then we use the diathermy when we are removing the breast from over the pectoralis. This is the full specimen, and this is the pocket, and the skin is healthy. And then we mark for the pathologist, and then we put the implant wrapped by ultra blue mesh, and the rule of the mesh is only to fix the implant if well fitted pocket, so we can omit the use of mesh, and then we put the implant covered by the mesh and close the medial limb of the incision, and then the circumareolar we close it. We use this technique to close the large circle over the small circle, and then after that the vertical limb is better to be between 5 and 8 centimeters. Then we close the vertical limb for 5 to 3 centimeters, and then the redundant part of the skin down, we deepthelialize this area and fix it. We shift from vertical to transverse or inverted T mammoplasty. As we can see, this is the left breast and right reduction mammoplasty. The second technique, and I think we always use this technique in the past, but this technique is more liable for complications and nipple areola necrosis. We put the implant, and then the nipple and areola based on the inferior pedicle, and then we close the inverted T, and then close as the previous case. These techniques, the blood supply in some cases of the nipple and areola is hazardous, and the inverted T, sometimes the T shape is hazardous, so exposure of the implant will finish the reconstruction. This case of multicentric breast cancer, and this technique we recommend if we will elevate the nipple and areola or mastopexy more than 2 to 3 centimeters. We start by removing the nipple and areola as a graft, because if the pedicle is very large, so and we need to decrease the pocket, we start by removing the nipple and areola, and then remove the retroareolar part, and send for frozen section to be sure that there is no occult carcinoma in situ or it's free. Okay, this is pouring, and remove the retroareolar tissue and send for frozen section. After that, we deepthelialize the lower part of the as an inferior pedicle, and then we start to dissect the breast completely. Start downward, remove this sling or the inferior pedicle. We dissect by the scissor, and then we start by dissecting the breast from the pectoralis. It will be make the dissection superficial is easier, and after that, like we doing the facelift, we dissect the skin from the breast, going to like we are doing the facelift exactly. After full dissection, we will mark the specimen for the pathologist because the upper or the retroalular tissue to mark it. As we can see, this is complete removal of the breast. After that, as we see, this is the skin. We close the vertical limb. We start by closing the vertical limb, and this is the lower dermal sling, or the as inferior pedicle, the skin without we deepithelialize it. We remove the part for the future nipple and areola, and then close the vertical limb. It is from 5 to 8 centimeters. After closure of this vertical limb, we put the implant. This dermal sling cannot completely cover the implant, so we put just a small part of the ultra pro mesh to and put the sling with small part of the ultra pro and fix the implant. After that, we close all the incisions, the vertical and the transverse incision, and we start by graft of the nipple and areola. We leave this grafting for about 8 days. We put it longer time, and then after that we remove the tie over. As we can see, this is the nipple and the areola. We did a mastopexy on the other side. This is the final result of the case. As we see in this case, the implant, if there is necrosis of the lower part of the inverted T, there is under tissue, so the implant will not be exposed. So I think this is a very good technique if we will remove or we need to reduce the pocket too much. Thank you very much.
Yes. Dr. Walid, thank you very much for this presentation. In your center, in your territory, in your patients, what is the instance of patient accepting the idea of reconstruction after you propose to her the idea of reconstruction? كم في المية من عيانينك يوافقوا على انهم يعملوا بريست كونستراكشن after mastectomy؟
هو في الحقيقة هم بيزيدوا، ولكن في الأول خالص كان الريكونستراكشن لا يتعدى عندنا أكثر من 10% ل 15%، ولكن with time the rate of reconstruction become more and more. Sometimes in our area the use of the implant and for the patient don't accept the implant at all in the past. Now after good explanation for the patient they accept, but still low, still not exceeding 30% of patients.
دكتور وليد شكرا على البرزنتيشن. كنت بس حابب اسال حضرتك، هو مع استخدام الديرمال سلينج دايما الانفكشن ريت بيزيد. What about infection rate in using dermal sling in your cases؟
هو في الحقيقه الديرمال سلينج لو حصل فيه انفكشن يبقى فيه نيكروزيس، يبقى there is necrosis, partial necrosis. But we did a lot of cases by, if we are in the good plane and with a good sling, I think the complication is very low.
What about thickness of dermal sling؟
The dermal sling, like you are doing mastectomy, you are going in the plane of mastectomy, like you are doing mastectomy the same.
No need for increased thickness.
No, the plane of mastectomy, exactly the plane of mastectomy.
Thank you.
I have a question regarding the infection rate he's talking about. We have three, we can use the ADM or the Vicryl mesh or the dermal sling. What we know is about the ADM has a much higher rate of infection than the dermal sling, or a lower infection rate.
I think we don't have ADM in Egypt.
Yeah,
We don't have ADM, so I don't have any experience with the
with the
ADM.
mesh. And what about the mesh?
But the dermal sling, this technique, what I did was the dermal sling exactly, it was to just cover the
lower pole of the implant.
The lower pole. And if there is any necrosis, so there is underneath tissue. But you know, the original of this technique using the not the silicone implant, the the polyurethane implant, which is fixed. But we are using this technique, the sling with the mesh to fix the implant because we don't have polyurethane implant. But what we did a lot of cases, and the rate of infection with the last technique is, I think, it's very low. But the mesh exactly only with the first technique. What if you saw it?
I didn't.
I think we have a lot of cases with necrosis of the skin and failure of the reconstruction, maybe due to infection.
And you do it direct to implant reconstruction? You do direct to implant reconstruction? Direct to implant reconstruction?
Yes. I'm always doing direct to implant reconstruction, because the expander, if you use the expander or two-stage, we have a concept of we're afraid from the radiotherapy and the capsular contraction.
No, I mean you put the implant subpectoral or under the skin?
Under the skin.
Under the skin directly?
Under the skin.
Yeah, okay. Thank you.
Thanks a lot, Dr. Nahas, for your presentation. Now we'll move to the next presentation. The title of the presentation is Guillain-Barré syndrome after Herceptin or trastuzumab treatment, a case report. Dr. Ahmed Naggar will do this presentation. Dr. Ahmed is working at Kabari Oncology Hospital.
Today we are going to talk about Guillain-Barré syndrome associated with breast cancer treated with trastuzumab, a case report. Acknowledgement. I'd like to thank my dear mentor, Dr. Islam Ramadan, for his support and helping me in this case. Islam يعني هو اللي بيحاولنا دايما rare cases. We present a case report of 52 years old female patient with breast cancer treated with trastuzumab, which is a monoclonal antibody against the HER2 receptor as a part of adjuvant systemic therapy. In our case, treatment with trastuzumab was complicated by the development of Guillain-Barré syndrome. MK is a 52 years old female patient with breast cancer since September 22, with past medical history was negative, no diabetes, no hypertension, or ischemic heart disease. Past surgical history, she underwent a appendectomy, cesarean section twice. Family history, negative family history. Oncological history. The patient presented to New Cases Clinic with left breast mass and left axillary mass. So investigation was requested in the clinic. Mammography, complementary ultrasound was done, shows dense irregular, not well circumscribed speculated mass located at 2 o'clock and measures and dimensions 24 millimeter, 9 millimeter, 20 millimeter along its main dimensions, and apart from skin void about 8 millimeter. Regarding lymph nodes, multiple ipsilateral enlarged spacious lymph nodes are of regular shape with phased hilum. The largest was 42 millimeter, 80 millimeters. After that, she proceeded for metastatic workup. CT chest was free, ultrasound abdomen pelvis was free, bone scan, mostly degenerative changes. Obtained a full biopsy, which revealed the invasive ductal carcinoma grade 2. The patient underwent left modified radical mastectomy with axillary lymph node dissection and go for pathology. Pathology report reveals invasive ductal carcinoma grade 2. 12 out of total 20 removed lymph nodes were positive. Here, hormonal profile was ER plus 3, BR plus 2, HER2 plus 3. KI 67, 15% activity. So, staging T2 and 3 MD. وصل الفكره البيشنت دي ريفيرد للانكولوجي كلينيك بعد ما كانت عملت السيرجري. I started adjuvant systemic therapy as follows: paclitaxel plus carboplatin as adjuvant chemotherapy, also trastuzumab plus pertuzumab for 6 successive cycles, اللي هو البروتوكول ال 3 weeks, started from December 22 to May 23. After that, she continued another 3 cycles of trastuzumab plus pertuzumab alone after the end of chemotherapy, from June 23 to August 23. Neurological history. During the first 4 cycles, the patient started to complain gradual onset and progressive course of bilateral lower limb numbness, started in distal fingers and toes, which is progressed proximally until it invades the whole limbs. And the next 2 cycles, dose reduction of paclitaxel was done by 20%, also adding medication to control neuropathy as gabapentin, pregabalin, duloxetine, but without any significant improvement. The new complaint of the patient is that she started to complain bilateral lower limb weakness. At the end of chemotherapy, the patient was referred to her primary consultant. He decided to continue her scheduled cycle of trastuzumab plus pertuzumab and advised her to continue medical treatment as mentioned. By May 23, patient continued only trastuzumab plus pertuzumab for 3 successive cycles, cycle 7, 8, and 9. By the end of cycle 9, the patient numbness and weakness increased in both lower limbs in a serious manner that made her become wheelchair person despite the medical treatment. الحقيقه ان الست دي كانت بتيجي العياده عندنا يعني كانت تيجي على رجليها، فاتفاجئنا بيها مع نهايه السايكل التاسعه ان هي جايه على كرسي متحرك. Patient was admitted to our hospital and further investigation were done. بدأنا بقى نبروسيد في الميتاستاتيك ورك اب بتاعنا. سيتي برين واز دون كانت فري، اكس راي ليمبس كانوا فري برضه، دوبلر بوست لور ليمبس واز فري، بون سكان ستيل no changes. The CSF examination was also free. So the patient was referred to neurology department in Alexandria Main University Hospital, and the patient was admitted there in August 23. Upon admission examination, Glasgow Coma scale was 15, pupil was round, regular, and reactive. Concerning sensory examination, superficial, upper limb and lower limb hyperesthesia, deep sensory, joint perception and movement was impaired. Motor examination, التون في الupper limbs كانت average, lower limb hypotonia, power as illustrated in the diagram. كان في decrease طبعا في الموتور باور بتاعت both lower limbs. كانت وصلت ان الرايت lower limb كان يعني اخذ degree 1 والليفت lower limb برضه كان قليله طبعا. الريفلكسز areflexia all over, coordination can't be assessed. Patient can't walk. Further investigation were done in neurology department, laboratory, CBC, liver function, kidney function, serum electrolytes, virology, thyroid function. برضه اتعمل لها serum protein electrophoresis عشان لو في معلومه عن كده. Time culture وكله برضه كان نورمال. السبيسيفيك انفستيجيشن بقى اللي اتعملت للكيس دي في قسم النيورولوجي اللي هي النيرف كوندكشن ستاديز showed low amplitude or obtainable compound motor action potential and reduced conduction velocities to less than 50% of lower normal limits in medial and left tibial nerves. Also decreased in sensory nerve action potential of medial, ulnar and pectoral nerves. الكلام ده موضح طبعا، والحاجات دي احنا حصلنا عليها يعني من قسم النيورولوجي عندنا. تمام. اللي على الرايت ده concerning the right median nerve، واللي على الليفت ده left tibial nerve. الاي ام جي اللي اتعمل بعديها كان فيه abnormal sharp waves and fibrillation potentials in the deltoid interossseous and tibialis anterior muscle. دي شكل الابنورمال شارب ويفز والفايبريليشن بوتنشال، برضه احنا حصلنا عليها يعني من قسم النيورولوجي عندنا. CSF examination repeated again كان تقريبا بعد حوالي 3 أسابيع showed immunopsychological dissociation elevated the CSF protein level accompanied by a few mononuclear cells. The protein level was 1.1 gram per liter. Unfortunately, examination of Campylobacter jejuni serology and anti-ganglioside was not performed. Differential diagnosis برضه الديفرنشال diagnosis ما كانش related لحاجات عندنا في الباثولوجي، كان برضه حاجات كلها related للنيورولوجي، حاجات زي التاكسانز induced peripheral neuropathy، ودي differentiated ان هي بتبقى mainly sensory، الchronic inflammatory demyelinating polyneuropathy ده بيبقى الكورس بتاعه بيبقى لونج على المدى الطويل، يعني اكتر من حوالي 8 اسابيع بيبقى كرونيك. المايلينيا جريفز الديمايلينيشن او المايلين شيدنج بيحصل في السي ان اس السنترال نيرفس سيستم. مانجمنت patient was treated with corticosteroids as a schedule betamethasone 14 milligram once weekly in the first month, 14 milligram every 2 weeks in the second month, and then once monthly. والبيشنت كانت admitted طبعا، فكان بيعملها monitoring كويس جدا للريسبيراتوري فانكشن والديجليتيشن بروسيس to follow any disease progression leading to respiratory distress او dysphagia. In case of disease progression, the patient will be planned for plasmapheresis and IVIG. اللي حصل بقى ان الست جابت ريسبونس يعني مايلد امبروفمنت في الماسل باور على التريتمنت بتاع الستيرويدز، لدرجه ان الماسل باور بتاعتها اتحسنت شويه، يعني وصلت 3 من 5 في اللور ليمبس، وده كان جريد كويسه بالنسبه ان احنا كنا 1، يعني كمان كانت 0 ل1 يعني. ان هي بتعمل الكونتراكشن بس not against gravity يعني اللي هو سكور 3. Patient then started physiotherapy. Patient continued medication with pregabalin, gabapentin, and duloxetine. Conclusion: the Guillain-Barré syndrome is an autoimmune polyradical neuritis with ascending muscle paralysis resulting from autoimmune peripheral nervous damage. The onset of it usually preceded by infection, mainly GIT infection, Campylobacter. The infectious agent induces production of antibodies which cross-react with antigen like gangliosides, glycopeptide present in myelin and in peripheral nervous system. The autoimmune reaction results in lymphocytic infiltration of spinal roots and peripheral nerves, may be involved in the axons and peripheral nerves, leading to macrophage-mediated multifocal stripping of myelin. This is classically presented with progressive descending weakness, phased reflexes, peripheral paratitis. دي طبعا الانواع برضه يعني دكاتره النيورولوجي طبعا هم اللي قالوا لنا عليها. يعني هو في 4 فاريانتس، كل واحد فيهم ليه الانفولفمنت بتاعه وليه البرزنتيشنز اللي بتبان في الاي ام جي والنيرف كوندكشن ستاديز. acute inflammatory demyelinating polyneuropathy والاكيوت موتور اكزونال نيوروباثي والاكيوت موتور سنسوري اكزونال نيوروباثي. هو ده النوع اللي البيشنت بتاعنا دايجنوز فيه. والميلر فيشر فاريانت ده بيبقى معاه اوفثالموبليجيا، بيحصل باراليسيس في الاكسترا اوكيولار ماسل. ده هنعمل كده صغيره. In our case, we present a patient who developed acute motor sensory axonal polyradical neuropathy, which is a severe form of Guillain-Barré syndrome, which involves both motor and sensory مع axonal involvement. After the treatment of trastuzumab as anti-HER2 monoclonal antibody, the diagnosis was supported by the patient's clinical presentation, CSF analysis, EMG, nerve conduction studies. Finally, there is a suspicion that the complication might be associated with trastuzumab or Guillain-Barré syndrome appeared as a paraneoplastic process. طبعا البرزنتيشن بتاع الجيلان-باري بوست ترastuzumab ده حاجه فيري رير. يعني عندنا في اخر حوالي 7 أو 8 سنين كان في 2 كيسز around the world، او دول اللي انا قدرت ان انا اجيبهم. دلوقتي يعني نقدر نواجه لحضراتكم بقى اسئله. يعني هل المفروض ان احنا نوقف الترastuzumab؟
هو السؤال بس الأول قبل ما نوقف التراستوزوماب, how do you relate Guillain-Barré syndrome to trastuzumab in specific? Why not pertuzumab? Why not both of them? Why not the combination? This is the first question I would like to ask you about, because this will guide the treatment. Because if this is the case, we can stop them. Why not? We should stop them. But how can you relate this to this specific drug? You already said that Guillain-Barré syndrome is preceded by viral infection, usually in the GIT. So why not this is a coincidence and not a relation between the drug and the syndrome?
هو الGIT infection هو ده بس اللي بيتريجر الموضوع.
Yes, but this is the common trigger in most of the Guillain-Barré syndrome, even if they are not receiving trastuzumab or pertuzumab. So how can you relate this to the drug in specific?
يعني البرزنتيشن بتاع البيشنت هو ما كانش يعني الست كان
عندي سؤال بس يعني سبيسيفيك للحاله وكومنت خاص بالحاله دي. اولا هي الستيجنج كان تي كام ان كام؟ معلش اي مسدت في
الستيجنج تي 2 ان 3 ام 0.
اوكي. يعني هنا ماي انبوت على البوينت دي بالذات ان عيانه فيري هاي ريسك لايك ذات وبتاخد ادجوفنت تراستوزوماب او مش بتاخد، يعني ايا كان بعد الجراحه، العيانه دي at a very high risk to develop either parenchymal brain metastasis, either meningeal carcinomatosis وهي السبيسيفيك جدا بالنسبه للسيناريو اللي حصل ده، او طبعا metastasis in another sites زي البون او زي ال يعني ايه او نيرف كومبريشن او هكذا. انا عارف ان هي اوريدي يو ديد ستيجنج ويو اكسكلود ده، لكن اللي صعب جدا تو اكسكلود بالستيجنج هو بالستيجنج تيست العاديه هو المينينجيال انفولفمنت. دلوقتي الايونز نزلوا من حوالي شهر جايد لاينز جديده على how to stage and how to treat meningeal carcinomatosis. واتس كلير انه stage 1 of the or type 1 of the meningeal carcinomatosis you see negative imaging. والحقيقه علشان to exclude it بسي اس اف cytology you need to do يعني specific يعني لازم يكون ايه very rapid very fast cytology. هو جي اس اف cytology اقصد very rapid very fast repeated سي اس اف cytology.
هو repeated بالفعل واحد في القسم وبعدين هو اتعاد تاني. يعني هو اللي اتعمل في الاول كان نورمال،
تمام،
بعد 3 weeks اتعاد تاني في قسم النيورولوجي.
انا I agree. I'm not questioning the diagnosis. Already you established it in a multi-step. لكن هنا بس for the audience لو عندنا 100 عيانة بالشكل ده، واحدة منهم هتطلع Guillain-Barré syndrome و99 هيطلعوا disease progression metastasis either in the meninges which is very difficult to treat. من كل 100 حالة منينجيال ميتاستاسيس 80 بس اللي بيتشخصوا بالتست و20 they are negative in CSF in MRI وبنعرفهم ازاي؟ بعد شويه بيبقوا بوزيتيف يعني كانوا السيمتومز بدات النهارده والديسيز بدا my real advice for that lady keep an eye on her بالscreening tests later on طبعا it's a very good يعني fortune ان حصل improvement على الستيرويدز لانه ده بالرغم ان هو ممكن يحصل في الميتاستاسيس برضه لكن الحقيقه الدراماتيك امبروفمنت denotes اوتو اميون ديسيز اللي اوريدي وصلته مش التشخيص فده هاي فكره بقى ايقاف التراستوزوماب I would not الحقيقه I would keep على التراستوزوماب والبرتوزوماب
كمان ان هي ما اخدتش نيو ادجمنت يعني
لانه الايجنت زي ما الدكتوره قالت الايجنت يستيل ما تعرفش ايه هي في طبعا ممكن في الكلينيكال فارماسي او في الفارماكو يعني فيجيلانس ممكن يعملوا اوتو انتي بودي اسسمنت يعني انتي تراستوزوماب انتي بودي او انتي بيرتوزوماب انتي بودي يعني بس طبعا I'm not sure اذا كان ده افيلبل هنا لو حد من الفارما لا برا خلاص هو دي نقطة تانية لأن ممكن يكون هنا بقى لو فيسجو ففي احتمال إن يكون أجنست البيرتوزوماب أو التراستوزوماب أو الهيرونيديز. لا ده أوبشن إن أنا أفصلهم. خليتهم بدل 3 يبقوا 2.
هي الفكرة بس في البنفيت versus الريسك بتاعت البيشنت يعني لو هي she will develop Guillain-Barré syndrome again she may die صح؟ فإذا كان البنفيت from the trastuzumab per pertuzumab is higher than her risk for developing the disease again I think we should stop it. I'm not a medical oncologist but this is my opinion. ما هو دي الفكره ان هو ممكن ما يكونش اصلا له علاقه بالادويه خالص يكون التريجر حصل وعمل الاوتو اميون ديزيز والاوتو اميون ديزيز ده هيبقى موجود وات ايفر خدت تراستوزوماب او ما خدتش زي اي حد بيجي له جيان باري سيندروم ودي حاجه
متاح التحليل اللي هو السيرولوجي بتاع الكامبايلوباكتر
انا فاهمه طبعا بس هي اذا كانت ريليتد للدراج دي should be reported this is very important وعلشان كمان لما العينه هتاخده في النيو ادجوفنت سيتنج هيبان القصه دي فما تاخدوش في الادجوفنت سيتنج او نشوف لها another alternative فلازم تشوف الريليشن شيب between the drug and the complication. Okay. Any other questions?
في سؤال تاني برضه يعني الستيرويدز will be sufficient or the patient will need IVIG for plasmapheresis يعني على الريسبونس اللي حصل.
انا معلوماتي يعني ان الاستيرويد زي اللي بتعالج كل حالات الاوتو اميون ديزيز هي الكورتيكوستيرويدز اصلا هي اللي بتعالج most of the autoimmune disease are treated by pulse steroids او by long term use of steroids. IVIG والplasmapheresis I think from my own knowledge يعني they are only used in acute cases. When steroids fail, pulse steroids fails, you can use the IVIG and the plasmapheresis, and you should be sure that there are antibodies to be removed by the IVIG and plasmapheresis because these techniques are not without complications. This is my own knowledge. I'm not a neurologist too. Okay.
Any questions?
So I'm pleased to introduce Professor Sara, Professor of Breast Cancer Surgery from UK. And we have yesterday a very hot and long day at the MDT, and she has very insightful recommendations. And we are pleased to have your lecture, please.
So first of all, thank you so much for inviting me here. Professor Elder, it's been just such a pleasure to be here and to be able to be part of the MDT, to be able to exchange ideas. My practice is in the UK, which is a very different phenomenon from the challenges that you face. The young patients you have to look after and that you are involved with carry with them so much challenge that it's been a privilege to learn from you today. So I'm really pleased to be here and to be able to talk to you a little bit. But please remember, I'm from the UK, so it reflects a UK practice, which is a little bit different, but I hope has some good messages for you. So what is an acceptable mastectomy rate? So I've been a surgeon in the UK now for quite a long time, and I have seen the survival rates of breast cancer reverse. So when I was giving talks to the medical students when I was a trainee, the survival was more like 30% with a 70% overall death rate from breast cancer. And I've seen that tip on its head in my career, which has been a huge privilege. And listening today, you're going to see similar changes over the coming years. But the big change has been the teamwork. And the first talk of the day that I was able to listen to at this conference was how oncology and surgery need to work together and the impact that that has on our patients. Now, this is a very surgical topic, but as I said at the MDT yesterday, if we're to take our patients with us, we have to speak with a single voice, both oncologist and surgeon, radiotherapist, geneticist. We have to have a single message or they will not believe us, because the patients at the end of the day want to live. And some of these discussions are really difficult because they have such a responsibility to survive, both to themselves and to their families. Within the UK, we have our own screening programme, and again, I was so delighted to hear about the screening programme and the impact that that has had on earlier presentations for your patient group. The screening programme in the UK was brought in the 1990s, and it came with it a very clear data collection, which was really different and that really impacted the surgical practice in the UK. So every surgeon that took part in the national screening programme would have their data delivered to them every year. So I would know what my mastectomy rate was every year of my practice. And that's quite a challenge, because what I thought was my mastectomy rate and what was actually my mastectomy rate vary very considerably over time. Next slide, please. Could I have my next slide, please? Oh, sorry. So I come from a little part of the UK called East Anglia. So this is the view. There is a beach near my hospital. It's a 20-minute walk to this very beach. So I'm very fortunate. And as you can see, I'm on the little bit of UK that is closest to Europe. I often say to my colleagues in London, I'm closer to Holland than I am to them. So why am I here today? Well, people think that mastectomy rates is about patient satisfaction, and it is, and I think patient satisfaction is really important. But better outcomes, are we collecting the data on the better outcomes for our patients? Do we collect, we call them PROMs, patient-related outcome measures? And do those better outcomes mean both oncology as well as cosmesis? Often cancer patients, I think, feel that they need to sacrifice cosmesis in the face of their oncological outcomes. We have increased numbers of patients. So I've seen the overall breast cancer incidence rate increase from 1 in 11 to 1 in 7 in our country. Across the world, it's the biggest killer of women within the cancer that's being treated, and so the importance of the quality in terms of our survival rates. And the other reason I'm here is Ibrahim Salim, who came to work with us in our unit and explained how things worked in Egypt and broadened some of my horizons, but equally to understand a little bit more about some of the impact of breast cancer outside the UK. He also brought with him a passion for trying to reduce the mastectomy rate. So this is an example of the data that I would get from the screening programme every year. This is separated into the various regions of the UK. So I work in the third one down, the east of England. This is one trust, and it says how many breast cancers are detected. This is in the national screening programme. So that's about a third of my practice. And then because they're small numbers, they usually look at it over 3 years, and you can see what the mastectomy rate is for non-invasive disease. As part of the national screening program, we pick up a lot of DCIS, and so that is a very important part of the work that we do. But you can see that even in this cohort, which is 2013-14, so 10 years ago now, our mastectomy rates varied significantly from 27.9% to 53%. And some of that was sometimes based around whether people felt comfortable with reconstruction. So would you prefer to do a mastectomy with a reconstruction and think that that might have a better surgical outcome for the patient than a wide local excision that might leave you with a very distorted breast? And we were basing our advice to patients and our advice in terms of oncological outcomes on some of the data, which is an example of which is here from the New England Journal of Medicine. I appreciate this is old, but this is the data that we were using at the time. So breast conserving surgery and radical mastectomy didn't have a difference in terms of long-term overall survival, but there was a difference in local recurrence rates. And I think that has always preyed on our minds and had an impact on some of the decisions that we were making. So this would be a standard outcome for a patient. I'm a surgeon, I'm sorry, and I apologise if there are too many pictures. So this lady's clearly had a mastectomy and radiotherapy, and this is her long-term outcome. These patients have an 85% survival rate, and so this is what she's going to live with for the rest of her life. Do we need to change? These are some old, I'm grateful to say, pictures of wide local excisions. And is that better than the mastectomy that I've just shown you in terms of purely looking at what a lady is living with? I think we did need to change. And this is an example, and I'm very grateful to my colleague Ruth Waters, who is a plastic surgeon and was former president of the British Association of Plastic Surgeons, and shows you the before and after photos for these ladies. And I think that gives you an explanation of why we needed to change. We now come to choices. Patients find it so difficult, and I'm sure you spend a great deal of time talking about the choices. Oncology has changed immensely, and trying to take the patients with you in terms of them understanding those choices, it's really difficult. I'm really pleased to say that as surgeons, our choices have also increased, and so making those choices becomes more complex. I happen to be also chair of the National Training Committee in the UK for general surgeons, so that's across all different specialities, upper GI, lower GI, etc. And I'm a training program director. And so I spend quite a lot of time explaining to my non-breast surgical colleagues exactly what breast surgery now involves. In the UK, breast surgery is quite specialised practice, and most UK breast surgeons do breast surgery alone. This is a Grissotti flap. One of my colleagues showed me a lovely Grissotti flap that he'd done himself, and is one of my favourite operations. In the past, we would have recommended a cancer behind the nipple meant a mastectomy. These patients are so much better served by a Grissotti. We also use reduction mammoplasties. Once we got together with our plastic surgical colleagues and we were talking to them, they explained this lovely operation that they make a lot of money from, that is a reduction mammoplasty. So you have a more youthful breast, and it's very popular amongst ladies in the UK. And you can use these techniques to remove large areas of the breast, but leave it with a cosmetically acceptable result. And for some of my patients who are in an older age group, who have very large ptotic breasts, they actually see their positive outcome of their breast cancer surgery. So they come back and say, I like what you did to my cancer breast, can I have the same done to the other side? Fortunately, that is still funded in the UK. But again, there are choices of how to do it, and choices that you can tailor to the needs of each of those patients. This is a patient of mine who needed a large area removing from her right breast, so she's had a reduction mammoplasty, and I then went on and symmetrized it because she preferred the side that I treated. We also use filling techniques so that we can remove a large area and move tissue in from the lateral side. This is a modified LICAT breast. You can see that she's had what we call a lazy S incision on the lateral side, and we've taken skin and fat from that incision in an ellipse and moved that to fill the upper outer quadrant of her breast. So she then still has a fairly symmetrical result despite having had a 4 centimetre tumour removed. What's happening in other places? So these are the results of a study carried out in Norway, and you can see that in younger patients, the mastectomy rate has steadily reduced over recent years. Most of my patients are elderly, so some of the techniques I use are very much based on what's the safest, what gets them through the surgery, recovered and onto their radiotherapy or their chemotherapy. And this is called what we call a batwing mammoplasty, but it gives a very safe, quick surgical result without a mastectomy. This patient likes this shape of her breast. She doesn't mind that one nipple's a bit higher than the other. She's 78. So even in the older women, the mastectomy rate is coming down, and that might seem strange, but they are in some ways the ones that need the most convincing. So often the patients will say to me, I don't need my breast, just get rid of it. But the data shows that actually it has an impact now on survival. So there is increasing evidence that breast conserving therapy with radiotherapy gives better long-term survival for our patients. I am having great trouble convincing my patients that losing your breast does not buy you time, but I am working hard at it, and I hope we're going to get there in the future. This is a patient of mine I did 10 years ago with a cancer on the left who's had an implant-based reconstruction. She already had large implants in before she had her breast cancer. This is a problem we regularly face in the UK, and so the actual thickness of her breast tissue was about 1 centimetre. So the mastectomy was challenging, but we managed to get it to heal and get her a reasonable cosmetic outcome. But I know I will need to come back and revise her, because implants last a period of time, which might be 15 years, but by the time my oncology colleagues have bought them 40 years, that's just going to mean more surgery. So if we can avoid the mastectomy, then that's by far in the best interest of the long term for the patient. I promised I would show the photos of my patient with my largest implant. This is a 1000 cc implant on the left on this lady, and you can see it nearly disappears. If I could have avoided a mastectomy for her, that would have reduced her surgical risks significantly. It's all about teamwork, so this is my team. Professor Sue Down is my co-worker in terms of general surgery and breast surgery, who leads our unit, and the gentleman caught in the middle between us is our plastic surgeon. We work very closely, we work as a team, just as you all demonstrated to me in the MDT yesterday. Thank you very much.
Thank you very much, Dr. Sarah, for your excellent presentation. I would like to ask you a few questions. What about decreasing the mastectomy rate to 0? How can we do this? I know it's very challenging, especially here for our patients who are having locally advanced disease, mostly. This thing is getting better now. 20 years ago, we used to have a very high rate of mastectomy, and now it's decreasing. But there is another trend in the world to do a contralateral prophylactic mastectomy, which increases the rate of mastectomy actually. Also, the bilateral prophylactic mastectomy for gene mutation is also trending. So how can we balance what you want to do?
There are patients that will always need a mastectomy, and risk-reducing mastectomies, the evidence in terms of that survival benefit and actually avoiding getting a breast cancer is very clear. And certainly we do bilateral mastectomies for BRCA carriers, but we have a similar problem that there are lots of patients for whom the breast cancer diagnosis is so devastating. Their initial reaction is just, I want rid of them both, I want them both gone right now. But the evidence is that that does not improve their survival. And it's how we communicate that to the patient. There is absolutely no evidence of improved survival with a contralateral mastectomy. And how can we as oncologists be doing surgery that increases their risks, so increases their risks of delaying their oncological management, increases their risks of long-term dependence on further surgery for absolutely no oncological benefit. You know, we have to convince them, and that's why I started with, we have to have the same message from all of us. We have a lot of work to get the public to understand that losing your breast does not improve your life, and it's not a matter of cosmesis.
But in your opinion, how can we decrease the rate of mastectomy and increase breast conserving surgery here in our group of patients?
Well, I think you're already doing a fabulous job by demonstrating that with earlier detection, you have less advanced disease, which gives you far more options.
Yeah.
The absolute drive towards neoadjuvant treatment to reduce is really important. And I think there is still that thought that actually downstaging a tumour to reduce a mastectomy is about cosmesis. It's about survival. You know, if you saw that survival benefit between mastectomy for a drug, you would be giving the drug.
Yeah.
So why are we not doing the same for breast conserving surgery? I think the neoadjuvant side of things is really important, but having the confidence that when you have done the neoadjuvant treatment, that you can do breast conserving surgery is equally important. And I think over time, gathering the data, reassuring yourselves that that is safe and best practice is just going to be important, because we are still really, with neoadjuvant therapy, still quite early in a breast cancer evidence. As some of my earlier presentations have showed, you really need 10 years of data. We'll get there, I'm absolutely sure, but I think the drive to neoadjuvant treatment is really important too.
Thank you. Any other questions? Okay. Thank you, Dr. Sarah. Thank you very much. Oh, you have a question? Yes, please.
In one of our Arab conferences on oncology and dealing with breast cancer, the question arises that are we different in the Arab world? In fact, a good initiative for the presidential initiative of breast cancer screening program, women education. Women education is very important for the woman to self-examine herself. This would be a very important for early detection and early screening programs. And also the educating the women not to exaggerate or to get to be exposed to exogenous estrogens, because this is also frequent in the Arab world. I think this program, starting with women education, would achieve or would provide achievement for the early screening programs that we are undertaking here in Egypt. And also screening programs are medically insured by the government, and also screening is insured by the government. And I think this will be a step forward to reduce the rate of mastectomy or extensive mastectomy or radical mastectomy, and maybe in the favor of doing modified surgery or minor surgery for breast conservation. Thank you.
I agree completely. Early detection is so important, but taking the fear away of the breast cancer diagnosis. I have spent my life telling patients, when you think of breast cancer, if you can add treatable on the end, that's so important. So many women see it as a death sentence. And I think that message in the public is really important.
I want to add that training also is very important, training of the surgeons to do the different types of oncoplastic surgery, including extreme oncoplasty, is very important to make the breast conserving surgery rate higher than what it is now. Besides, as you said, the breast cancer awareness campaigns and education of the patients, I think all these factors together with the presence of the drugs needed and insured by the government will make a difference in few years coming.
We just need to keep working together.
Yeah, thank you very much. Okay. Thank you very much. Now we'll move with our last presentation. It will be presented by Professor Dr. Luai, Professor of Medical Oncology at Qasr Al-Aini, Cairo University. This will be about residual disease after neoadjuvant treatment, how to deal with the non-PCR. Okay.
Thank you, Mr. Chairman, and thanks to the organizing committee for inviting me. Now, as you've heard today, one of the very preferred approaches to treat our patients today is neoadjuvant therapy. We give neoadjuvant therapy for large disease. We give neoadjuvant therapy for some small diseases, but aggressive subtypes. And we give neoadjuvant therapy to attain breast conservation, even if the disease is not large and if it's not aggressive. So, these are my disclosures. But why do we care to achieve PCR? Because if we give neoadjuvant therapy for a large unresectable disease, and it is resectable after neoadjuvant, then why do we care about specifically achieving pathological complete remission? Why does the disease have to disappear? First, because we've known from this meta-analysis that if you give 100 patients neoadjuvant chemotherapy, and back then it is only chemotherapy. There was no anti-HER2 or even immunotherapy, of course. That in specific aggressive subtypes, like the triple negative breast cancer in the bottom and the HER2 positive, you have very different prognostic outcome and very different long-term outcome if the patient achieved PCR in the red line, where you have less than 20% of them are relapsing, compared to the blue line, where those who did not achieve PCR, half of them relapse and half of them die of their disease. Even in the hormone receptor positive HER2 negative patients. In this meta-analysis and in other studies, it is also prognostic, meaning that those who do not achieve PCR, they do worse, irrespective of your treatment later on. So, we have a residual disease after giving a neoadjuvant chemotherapy. Are all residual disease the same? Do we fear all of them on the same degree? They're not. As we can expect, it depends on the size of the disease. So if a 1 centimeter disease is not like a 10 centimeter residual. In addition, the disease biology, as you have seen before, the disease biology makes the difference. If it's a triple negative disease with a residual disease after neoadjuvant chemo with no PCR, then this is a real problem. Again, more than 50% will relapse. If this is an ER positive HER2 negative, this is not a very big deal. The relapse rate is higher, but it's near to those who achieved PCR. If they received, of course, adjuvant endocrine therapy. And finally, it depends also on the neoadjuvant therapy received. Because in some patients, they do not complete the neoadjuvant therapy. If they received 2 cycles of neoadjuvant therapy, then went straight to surgery, having residual disease then is not as poor prognostic factor as if they have completed the whole neoadjuvant therapy. That's why we advise today to complete the whole course of neoadjuvant therapy before going to surgery. So, again, assume that's the breast and that's the tumor size we started with. If we had such a small residual disease after neoadjuvant chemotherapy, it will be very different to if we have that residual disease. We have less than 50% reduction. We call that a stationary disease on neoadjuvant chemotherapy, or another term called sluggish response. In some patients, we have a disease that is progressing on neoadjuvant therapy. That's around 10% of all patients. In those patients, the disease, while taking the chemotherapy, it increased in size. It's very clear for you now that the volume of the disease, the course during neoadjuvant chemotherapy, is associated with the survival. And now we can quantify how big is the residual by using the MD Anderson Cancer Center calculator for residual cancer burden of the disease. You enter, it's just an online calculator. You check your pathology reports. Some pathologists, they started already reporting the residual cancer burden, so they do the calculation for you. But if they don't, you can do it. You put the primary tumor bed area. That's the area that's firm, gritty, grayish part in the specimen, not the yellowish fatty part. And you quantify the cancer cellularity as a percentage. The pathologist usually say you have a 90%, 50% necrosis, for example, and the rest are alive tissue. You have also to report the percentage of DCIS, of the in situ component. If you did report that, then the system already subtracts and gets the residual viable part. You also have to put the positive lymph nodes number and the diameter of the largest lymph node, and the pathologists also say that. Then you calculate and you find here a residual cancer burden score, that's here 3.8 for one of my patients, and the class, it's class 3. And according to the residual size, we classify into class 0, that's typically the PCR, those who did not have zero disease. And class 1, very small residual, class 2, intermediate, and class 3, very large residual. And as you can see, this patient only had a residual tumor bed of 15 millimeters. She had only 4 positive lymph nodes. So it doesn't look like as large as you'd expect with a 10 centimeters tumor, for example. But lymph nodes does count. So the number of lymph nodes and the size of lymph node does count in the long-term prognosis. That's the patient survival. If you have waited for like 10 years and followed up patients who achieved PCR in the dark blue line compared to in the red line, they had a small residual. Well, not very bad, but again, they are worse than those who did achieve PCR. But if you look at the blue line, those who had large residual, again, like 60% of them, you tell those patients, Mabruk, you have been cured, you've responded on the neoadjuvant therapy, you did a successful surgery, and you're cured. 60% of them will die of breast cancer. Bottom line, the bigger the residual, the worse the prognosis. The disease biology does count. And here you see, even between the small residual and the large residual, you see how different it is in the triple negative breast cancer. In those patients, the large residual, so if the patient who had 4 positive lymph nodes in the sample and had a 15 millimeters residual, she's an RCB class 3. That's in the light blue line. If you look at the prognosis kinetics, you see that almost 80% of them, they relapse. And when do they relapse? They relapse in the first 2 years. So it's typical of those patients with triple negative breast cancer and large residual that during adjuvant radiation therapy, during the first visit after surgery, you can find if she complained of any chest wall complaint, breast complaint, you should examine her and you should schedule for her a breast exam or a metastatic workup of that if that complaint is systemic, because you have an 80% chance of them to relapse within the first 2 years. In HER2 positive breast cancer is not as bad, but again, in the RCB class 2 and 3, those with intermediate and large residual, 50% of them, they do relapse within the first 2 to 3 years. And finally, in the ER positive HER2 negative, it's totally different. So if you look at the first 2 to 3 years, most of the patients are really cured, but the relapses accumulate with time following the years up to 12 years, patients are still relapsing. They are relapsing one by one, month after month. So you do not have a drastic fall in the prognosis. Most of the patients really are cured, but you have to follow them up for a long period because some of them, like 20 to 30% of them, will relapse after the first 5 years of follow-up, where you tell them really, مبروك. مش مبروك قوي في ال ER positive HER2 negative breast cancer. But if we go back, one of your patients, even with residual disease and triple negative breast cancer and HER2 positive breast cancer, at follow-up year 6, I would tell her Mabruk, because she really passed most of the expected relapses. So her chance to relapse after year 5, even if she had no PCR, is around 5%. Again, her chance to relapse in the first 5 years are around 80%, but if she passed those 5 years, it's around 5%. So, please ensure that your patient receive adequate therapy and adequate duration of that therapy. So, can we assess the residual disease or the non-PCR if they received neoadjuvant endocrine therapy? Well, the answer is yes, but here we do not assess PCR or not. We do a score to quantify the size of the residual, and we do a score to quantify the ER, PR, and Ki-67 status, for example. So that's called a PEPI score. And here, you can see that the prognosis is good, even if the patient had small residual like T1 or T2 and 0. That's a non-PCR, but they are in the blue line. That's a score 0 to 3. So if they have even a tumor that's 3 centimeters and no lymph nodes, they have very good prognosis. Poor prognosis only for those who have a large tumor or positive lymph nodes. And so quickly, we can look into our options. What if we have a patient with a residual disease and let it be large enough that we need to start adjuvant therapy following neoadjuvant therapy? In triple negative breast cancer, we have the immunotherapy, but that's only if your patients did start immunotherapy with neoadjuvant chemo. So if she has a residual disease after neoadjuvant chemoimmuno, here, these data tell us that in the residual disease, well, they're both bad. Those who received immunotherapy and those who did not. But immunotherapy makes a difference of around 10% in the long-term outcome. So, we all know the CREATE-X study where patients who here were all HER2 negative. So half of them or more were triple negative, and the residual disease were randomized to no treatment versus capecitabine, the oral chemotherapy. And here you can see that you have a 30% improvement in disease-free survival in the triple negative breast cancer cohort, and that's also in the overall survival. However, this is only in Asian patients. This wasn't confirmed in the non-Asian studies. So it is an option in our patients as well. Finally, if this patient had BRCA mutation and she would be eligible for the Olympia study that randomized patients with BRCA mutation, triple negative breast cancer here, and prior neoadjuvant chemotherapy with no PCR, just like our scenario. They were randomized to olaparib versus placebo, and the results was significant improvement in invasive disease-free survival and overall survival. And now the treatment is approved. It's present in Egypt, but not reimbursed. However, it is an option for this rare scenario where your patient has triple negative breast cancer and BRCA mutation. For the ER positive, HER2 negative, you have the additional endocrine therapy. But again, that's only in those with high risk. So you should, in patients with the monarch E, they should have 4 or more positive lymph nodes, or 1 to 3 positive lymph nodes plus an additional risk factors. This will typically no PCR. Again, this shows the improvement in the invasive disease-free survival, again, significantly compared to endocrine therapy alone. Same with the NATALEE study, but used ribociclib, another CDK4/6 inhibitor. So those patients had, again, could have N1 disease here. They shouldn't have N2 disease. And finally, the Olympia study, they included some cohort of ER positive, HER2 negative patients, so they might have as well go into the ER positive, HER2 negative, non-PCR cohort. Finally, the HER2 positive patients, and that's actually the first disease entity where we have already known that intensification of treatment for the non-PCR patients can result in a disease-free survival advantage. This is based on the Catherine study that randomized patients with this scenario into trastuzumab, the standard of care, versus the TDM1, the antibody drug conjugate, and it showed that patients on TDM1 have shown improvement in the invasive disease-free survival compared to trastuzumab. Unfortunately, we do not have the long-term data yet for this study, but if you have a patient today with a HER2 positive disease that did not achieve PCR, it is available in Egypt and it's reimbursed in Egypt to complete the 1 year of adjuvant anti-HER2 with TDM1. And again, don't forget, if your patient can tolerate TDM1 or if it's not accessible, you can keep on the dual blockade and not give the trastuzumab alone as in the Catherine study. And thank you very much. Thank you.
Any questions?
Thanks a lot, Luay, for this very nice presentation. Actually, we have multiple players currently in the adjuvant setting after neoadjuvant and triple negative. How we can overlap these players together? Like if we started Pembro already in the neoadjuvant setting, then we have residual disease. Could we add like Xeloda, like the capecitabine to the immunotherapy in the adjuvant setting? And if we have BRCA positive disease for these patients, how we can deal with this? Especially we have no evidence for that. Every trial come with separate players. So how we can integrate these players in the adjuvant setting?
Well, first, in the triple negative breast cancer with the non-PCR, it's a poor prognosis despite all the players we have. That's something that we should admit. Hence, we should look for the other players. In the BRCA mutation, where it's a rare scenario, so it's a 10 to 15%, we expect that, of the non-PCR. You can give olaparib alone or in addition to pembrolizumab. We have safety data, yet we don't have efficacy data. But what would I do if she has BRCA mutation? I will switch to olaparib. We have an overall survival advantage for olaparib. If we don't have BRCA mutation, which is the majority of our patients, I will add capecitabine to the pembro. If she was in pembro, and if she wasn't in pembro, if she was received only neoadjuvant chemotherapy, including carboplatin. A very important advice here: if you see that your patient during the neoadjuvant chemotherapy is not very well responding and she's not receiving carboplatin, please offer carboplatin during the neoadjuvant chemotherapy, so you can add it to taxane easily and safely.
You mean during the neoadjuvant?
The neoadjuvant. The neoadjuvant. Yes, because we shouldn't be surprised with a non-PCR. We should be assessing the patient every 2 to 3 weeks during the neoadjuvant chemotherapy. And if in the middle, by cycle 4, by cycle 5, she is not well responding and she's not receiving or not planned for carboplatin, هنحطه امتى؟ ما هو هنا احنا محتاجين نوصل للبي سي ار لان هو ده الفرق في السرفايفل. If we can add carboplatin then during your adjuvant, then fine. If it was added and again no PCR, then I will add capecitabine.
So you are going to use all the players in the adjuvant setting, combine them.
If around 80% of the patients will relapse in the next 2 years, so you either use them now or use them when she has metastasis. So you already use them anyway. You won't save it.
Well, I have a question for the ER positive, HER2 negative breast cancer. We don't have so much options if they are hormone resistant. What can you use as an adjuvant if they are hormone resistant?
Usually, we don't know after following the neoadjuvant therapy if they're hormone resistant or not, because most of the ER positive, HER2 negative breast cancer patients nowadays are treated with neoadjuvant chemotherapy and not neoadjuvant endocrine therapy. But for those who did receive neoadjuvant endocrine therapy and responded well, there's no need to introduce any chemotherapy at all. If they didn't respond well, just like you did, we have two options. That means PEPI score 3 or 2 or 3. So those we have two options. The first option is the classical, by all the guidelines, use chemotherapy. So we use adjuvant chemotherapy, and then we keep on the adjuvant endocrine therapy plus minus CDK4/6 inhibitors or PARP inhibitor. However, for some experts now, they do think for intermediate risk patients not to add adjuvant chemotherapy, but to add instead the CDK4/6 inhibitors for the adjuvant duration, that's 2 to 3 years, in addition to the 5 to 10 years of the adjuvant endocrine therapy for patients who are not willing to receive chemotherapy, and there are many, and for patients who would not tolerate the toxicity of chemotherapy.
I have a question. It's a comment more or less than a question. When you have a minimal residual disease which is treated by surgery, doesn't this is considered as a treatment for the minimal residual disease? Why do you overtreat the patient with adjuvant treatment afterwards?
Surgeons always consider they do treat the large residual disease.
Yes, we do.
Medical oncologists, we think they are not. We think the real disease is not in the breast. What kills the patient is never the breast mass. What kills the patient are the brain metastases. So how would the lumpectomy or the mastectomy treat the brain metastases that will happen in the next 2 years? Of course, it might add to the reduction of the volume of the disease and hence some treatment. But all those patients that I've shown that 80% of those triple negative breast cancer with large residual disease, they relapse despite having treated by surgery. So we have knew that we didn't know the information of the large residual disease only by doing a successful surgery.
Yes, but you are now treating like micrometastasis that we are not seeing. It's not a residual disease actually. It's a potential residual disease that we are not seeing, and we are trying to protect the patient from relapses after adjuvant treatment. But
it is potential. Yeah. It is potential residual disease, but its odds are 80% to happen versus 20% not to happen.
But not in every patient and not in every molecular biology.
Exactly.
We have the hormone receptor positive patients, except for the hormone sensitive patients who receive tamoxifen, they have a good response and they can prevent recurrence in 40% of cases. But we do not give chemotherapy for all patients, and despite of this, they don't relapse.
I totally agree with you on that point. Well, again, my question was in the sense of, or my answer was in the sense of the aggressive subtypes. But again, if you have an ER positive, HER2 negative patient that fail to achieve PCR or even have a large residual, then you are really treating her by surgery. Because if she did successful surgery, her chance of relapsing in the next 10 years are in the range of 30 to 40%, even with large residual disease. So again, those are treated. If you have a 40% odds, then the 60% prevails.
Well, this brings us to another question, which is why don't we do with complete response, complete clinical and radiological response, like the follow-up management?
Follow-up without surgery?
Yes, this is against being a surgeon, I know, but this is the logic too. When we have HER2 positive subtype and triple negative subtype, achieving up to 60% complete response, and then we do a mastectomy for the patient. I don't think this is right.
Well, I totally agree with you. There are some ongoing studies to test this point specifically, to de-escalate surgery or to omit surgery in those, specifically in HER2 positive patients. I think this will be the standard of care in the coming years for HER2 positive, at least, because most of them, they do achieve PCR. I'm afraid we're out of time because I'm getting signals that try to stop.
Thank you very much. We are ending the session now, and thank you very much for attending, and thank you very much, Dr. Loai.